everyone to someone who needs very little introduction to this audience, but I'm going to give him one anyways. Dr. Matt Schlenker is an assistant professor at the University of Toronto. He's a specialist in glaucoma, cataract, and anterior segment reconstruction at both the Toronto Western Hospital and Trillium Health Partners, as well as Kensington Eye Institute. What you may not know about Matt is prior to medicine, he had a whole other life. So Matt completed a bachelor's degree at Yale in economics and actually worked as a financial analyst at Bear Stearns. And Matt, I don't know, that might have been around the 2008. So you might have lived through some interesting times there. Following that, he completed his MD and his residency at the University of Toronto, and then went on to complete a glaucoma and advanced anterior segment fellowship also at the University of Toronto, as well as a Master's of Science in Epidemiology at the Harvard School of Public Health. And since then, he's come back on staff. He's been an instrumental member of the faculty involved with both resident and fellow teaching, and he's the chair of our resident research at DOVS, and we appreciate all of his efforts. So Matt, thank you for all that you do, and I'll hand it over to you for today's rounds.
Great. Well, thank you, Amandeep. I did work at Bear Stearns it was much earlier than 2008, so okay. I'm dating myself a little bit, but it was actually a very good time for Bear Stearns before they ran into some big problems. But anyway, again, thank you for that introduction. And this is when Alan came on and he said, "Is this on glaucoma?" And I said, "Well, actually, we're gonna talk a little bit about cataract, and this is not about how to make a capsulorhexis. This is not about the best phacoemulsification techniques." But I do think that that what we're going to talk about is actually just as important or more important than some of our surgical maneuvers. It's actually how we deliver cataract surgery in our society. And we've been working on this for a number of years. Most of this is done out of the Institute for Better Health at Trillium Health Partners, which is really a health services research think tank or institute. And we've, of course, because of Sharif and Kensington, there's been a lot of interest to do this downtown as well. We've been able to partner here, some in Hamilton, some in Queens as well, to do some of this research. And again, this more comes down to a few principles. One is we have constrained resources in our system, like many systems. And the idea is to make sure that we're delivering appropriate care and also prioritizing those who need it most. And those are going to be impacted most. And at the beginning, I used to always say, that ophthalmology, we're so behind in research and, we can borrow from internal medicine and other areas. But I have to say in this particular area, there's not a lot of research in general in other areas. And I'd like to think that some of our publications have been helpful particularly for ambulatory surgery in other areas where we grapple with some of these same issues that we do in cataract surgery. Something else that we're working on, and I think this this maybe did start in my life in the glaucoma, is this desire and need to focus on patient-reported outcome measures, so incorporating the patient voice and more shared decision-making in our day-to-day practices. And I said in glaucoma, this has been a bit of an issue in some of our studies because glaucoma is largely an asymptomatic disease, and then governments and agencies are imposing patient-reported outcome measures, again, for an asymptomatic disease. Well, the good news with cataract surgery is they actually do have symptoms, though a lot of the broader, well-known patient-reported outcome measures are not particularly sensitive to the symptoms that patients get with cataracts. And keep in mind, too, people have two eyes, and unilateral cataracts are very hard from a patient-reported outcome measure standpoint. So these are some of the areas we've been working on, and I've been very grateful to have many research students, two of which are going to present for us today, but I do not want to take away from many other people's effort. We've also had residents who've been very involved in this. We've had fellows, we've had researchers, again, spanning multiple institutions. We've had funding from industry, and more recently, we've had funding from CHR. I think it's very hard for ophthalmologists to compete against the neuroscience bucket in CHR, but there is a health services and policy area, and we've had a little bit more success in that area with CHR, and we're hoping for more. We've applied and will continue to apply to some of the larger project grants. So without further ado, I do want to allow both of our students. So Aman Sayal is a medical school graduate who's applying to ophthalmology this year through CARMS and has done a lot of great work with me and other people in this health services field. He's going to start his presentation. And then Diana Martinez, she's in her second year of research fellowship with us formally working on this. And again, she's also done a lot. So we are all going to learn from both of them. Anyone in the audience who sees cataract patients may be able to help us out. You know, I think it's very easy to get caught in your research, and we'd love to have clinical perspectives. So please either try to promote yourself so that you can speak, or put it in the chat if you have any thoughts on any of the research that we're doing. So Aman, why don't you go ahead?
Great. Just going to share my screen here. Can you all see this?
Yeah, looks good.
Perfect. Okay, well, it's an honor to speak to you all today about the optimization of cataract patients from the health systems, health services perspective. I'm going to speak to you a little bit about appropriateness and prioritization, and then I'm going to pass it off to my colleague Diana, who will speak a little bit about our current projects and next steps. And just wanted to extend a very big thank you to all those listed here for their hard work on this research. So our cataract surgery wait lists are getting longer. You know, our population is rapidly aging. We're resource limited. So I think it's very important that we talk about how to best determine appropriateness and prioritization in a very systematic and equitable way for our patients. But before moving any further, I think it's important that we distinguish the terms appropriateness and prioritization, because they sound very similar, but they're in fact quite different. And when I speak about the term appropriateness, I'm really answering the question, you know, is the patient sitting in front of me a suitable candidate for surgery? Yes or no? And when we answer this question, then we can really deal with prioritization. You know, how can we relatively rank our appropriate patients on a wait list so those who need care the most receive that in a timely fashion? When I speak about optimizing appropriateness, I'm really talking about direct healthcare cost savings to our system. When I speak about optimizing prioritization, it's really about indirect healthcare cost savings. And, you know, I'm speaking about these concepts like they're different, which they are, but we're really trying to accomplish the same overarching goal, which is avoiding unnecessary surgery and those who don't need surgery, and ensuring that our very limited resources are directed to the right patients at the right time. And I speak about appropriateness in this very dichotomized binary way. It's either you're appropriate for surgery or you're not. And as it turns out, Trillium Health surgeons also view appropriateness in the same way. So we surveyed surgeons at Trillium Health to rate their patients, rate how appropriate they were on a scale from 0 to 10, 10 being the most appropriate. And we really see two groups or two cohorts of ophthalmologists here. We have ophthalmologists either rating their patients as very appropriate, so giving their patients a rating of 7 out of 10 to 10 out of 10, as we can see here, or giving their patients a rating of not that appropriate, so 0 out of 10 to 6 out of 10. And something to note here is that 81% of patients who were referred to ophthalmologists were deemed appropriate. And I think it really begs the question, you know, if 81% of patients who are walking through clinic doors are deemed appropriate, is our status quo, at least from the appropriateness side of things, really that bad? And just something to consider and some food for thought as we work through the presentation. So we're ready for our polling question number one. We'd love to hear from all of you. Starting with the appropriateness side of things, in your opinion, what is the most important factor to consider when determining appropriateness for our cataract surgery patients? Is it visual acuity, patient-reported outcome measures, physician judgment, or none of the above?
Or all of the above.
Or all of the above?
Yeah. We'll let this run for a second. So, I mean, you've got a nice mix here. Okay. So a good mix of results there. Now we can see how that, I guess, visual acuity is still number one, but we can move on to polling question number two and see if that changes for prioritization. So in your opinion, what is the most important factor to consider when determining prioritization for our non-urgent patients? First come, first serve, visual acuity, patient-reported outcome measures, physician judgment, none of the above, or I guess all of the above as well. We'll give it a second to run here. Sounds good. So there's a bit more of an answer here. Physician judgment seems to be. Okay, interesting. So we'll discuss this as we move through the presentation.
Yeah, and I want to pause here too. It's interesting. So my sense when, you know, as I look at, you know, government documents, the way policy is going is that we are shifting to the patient having a lot more power and say. And we just had a poll where no one said that a patient-reported outcome measure, what the patient, you know, feels is most important relative to other patients from a standardized questionnaire is important for prioritization. What we did see, and again, I guess this is a physician-heavy group, that everyone's saying that the physician should be able to decide. And of course, the issue with that, I think the concern of that from government and policymakers is that that's not a metric. That's just kind of the doctors using the art. And so I think we're going to see some of the good and bad with doctors still using their art versus maybe trying to use hard metrics from a patient perspective. So interesting.
Okay, so my goal over the next few slides is to determine some of the tools in our toolkit to best determine appropriateness and prioritization for our patients. And I'm sure the first metric that everyone thinks about, is visual acuity. It's objective, it's standard of care. We've been using it for many years. It's easy to collect. A lot of people know what it means, and it's very easy to identify patients who have very poor visual acuity. But we're really missing out on the patient experience. What about those who experience glare, halos, and starbursts? Take, for instance, a patient who has a posterior subcapsular cataract. So they have a vision of 20/25 or even better. And, they're reporting a lot of these debilitating symptoms, but on paper, everything looks quite good. At the end of the day, too, we're all unique. So I think we all have different thresholds with regards to what drop in vision really bothers us. So for someone like me, if I lost 2 letters on the Snellen chart, that would really bother me versus someone who went from 20/20 to 20/40, as long as they can golf, everything's okay. And I think this study out of China really highlights the issues with using a single metric like visual acuity. So in some regions of China, they have hard thresholds of 20/40 or worse. So if you have vision better than 20/40, you are deemed inappropriate for surgery. But what a very bright group of researchers did was they investigated patients who had vision better than 20/40 and allowed these patients to go through cataract surgery. And these patients had significant improvements in visual acuity, objective variables like visual acuity, and self-reported visual function as well. And I think the bottom line here is that visual acuity, it's great. It can guide a lot of our decisions. But if we were to use it as the only metric, we would lose out on a lot of patients who could potentially benefit from cataract surgery as well. So that takes us to the patient's voice, patient-reported outcome measures. And this has been studied in other areas of medicine. So there was a randomized control trial out in Alberta, so the highest level of evidence, which indicated that surgeons who used PROMs when making hip and knee surgical decisions made those decisions with higher quality than those who didn't use PROMs. And with regards to ophthalmology, we do have a lot of options here, which a lot of you may have seen before. But the issues with these questionnaires is that there's a lot of social, legal, cultural, and technical barriers with implementing these into clinical practice. So our search for the ideal PROM tool continued, and we have a series of questionnaires here on some violin plots. And I think one that really stands out to all of us here is the CAPQuest questionnaire. On the x-axis, we have our 9 items. So we have our 2 global items and our 7 quality of life items. And on the y-axis, we have the possible responses that patients can answer to this questionnaire. And we can really see a good spread, patients responding at all levels of this questionnaire. And what I mean by a good spread is that we really have that good ability to distinguish between different levels of visual function. And when you compare that to, let's say, the EQ5D, where, patients are answering at the 1 and 2 level, but not really the 3, 4, and 5, CAPQuest is really great to allow us, to distinguish between who has very good vision, who has poor vision, and whose vision is so-so. And for those who haven't seen the CAPQuest, this is the questionnaire. So we have our 2 global items at the top right here, and we have our 7 quality of life items down here. So once again, it's really listening to the patient about how, vision impacts their quality of life. And our team did a lot of research on the CAPQuest questionnaire, and we found that it's a very valid and reliable tool in international populations, specifically in Canada and more specifically in Ontario. We found that it was responsive to cataract surgery. And we also asked ourselves the question, is asking a 9-item questionnaire to every patient that walks in, through clinic doors, the most efficient use of resources. So we took an evidence-based approach and we reduced the number of items to 3 items, and we found that the questionnaire actually performed just as well.
I just want to pause you there for a second, Juan.
Yep.
So, a big takeaway for me, and this is, I said, not only in the cataract space, but also in the glaucoma space, that if you're reviewing a paper or there's talk in your area of expertise that the EQ5D is going to be used, so the NHS in the UK really likes it, the NEI likes it as well, other areas of medicine like it, my strong recommendation is to just say no. that it is not an appropriate measure for cataracts. It's not for glaucoma. Maybe it is for cornea or retina. I'm not sure. I haven't done as much. I don't think so for cornea from what I've seen. That we have to be very careful that if you set the goalposts for a study in a way that there's no way to get a field goal, if you will, then your study is not going to work out. And it's incumbent on us, as I said, as clinical investigators and also evaluators, to make sure that the goalposts are aligned, so that, again, if the field goal is supposed to happen, then it can actually happen. And I said this, I think this has been a big problem. It's been a big limiting area for research. And I think it's made some people frustrated with PROMs. And it's not necessarily the PROMs are the problem. It's just that, again, the goalposts need to be aligned.
Okay. So, some of you may be wondering, patient-reported outcome measures, we're really listening to the patient's voice. It really alleviates a lot of the drawbacks of visual acuity alone. Why not just listen to the patient's voice? But there's also concerns here. Take, for instance, the elderly patient who indicates on their questionnaire that everything is just fine, but they're legally blind or unable to drive. I think we'd argue this is a patient who really needs cataract surgery. Or what about that patient, like I mentioned, who is 20/40, but they can golf and they have no other concerns, but there's also difficulty and risk of removing more advanced cataracts? And what about patients who want to answer the questionnaire in a certain way to see if they can receive an earlier surgery date? Then I also mentioned there's patients like me who have vision 20/20, they lost a few letters and they report everything's wrong. Can we really report or justify surgery in patients who have 20/20, both from a cost perspective, but also from a safety and risk perspective as well? So this patient's voice, which is really important, it's not well captured in the existing appropriateness and prioritization framework as it stands. So we looked at 3 PROM questionnaires, including CatQuest. So that was over 25 items. We did a multivariable regression, and we found that there was really only 1 to 2 PROM items that were associated with what physicians thought were important appropriateness and prioritization criteria. So some of you may then be wondering, what do the physicians value? And it may not be a surprise that, it's visual acuity, as we saw in that first polling option. And the worse the visual acuity was, the higher the appropriateness and priority rating, which was given by the surgeons. And this is a graph which indicates priority on the y-axis, but this was the same relationship that we found for appropriateness. We just didn't have a graph for that. And I did want to speak a little bit about the relationship between visual acuity and CatQuest, because when I started working in this area, I thought it would be a very strong correlation, when in fact, the relationship is there, but it's not that strong. And on the x-axis, we can see change in CatQuest score. On the y-axis, we can see change in vision. And we had about 61% of patients that had improvements in CatQuest and improvements in vision. And that makes sense. We also unfortunately had patients who had reductions in vision and reduction in CatQuest score. Unfortunately, that also makes sense. But we also have patients who have a reduction in CatQuest, but an improvement in vision, or an improvement in their CatQuest, but a reduction in vision. And that's a little bit harder to explain. And I think because these metrics aren't as correlated, it's even more reason to be using both, because both are providing us with unique data that would be missing out, if we were to focus on one or the other.
I just want to pause here. I'm on saying this slide. And I think some of the residents have probably heard me say this. So anytime we have data, we have to look at the data before we start using summary statistics for it. The most common summary statistic being, say, a mean. And if we're going to look at 2 variables, I think this is the best way to look at it, is a scatter plot. So before you start summarizing, you have to look. And you just have 1 variable, I think a histogram is probably sufficient. And this is almost like, in some ways, the researcher's worst nightmare when you see the scatter plot and it looks like there's not a lot going on. I think Aman just articulated this one well. There are some, there's clearly not a good correlation between the two, and this is what speaks to high contrast visual acuity in the physician's office may or may not be indicative of how the patient's actually functioning using a fairly well validated questionnaire. And vice versa, if you just use the questionnaire, well, then you're losing out on visual acuity, which for patients who can't advocate for themselves is quite important as well. So this is one of the few times where I looked at the scatter plot and it looked like it was not a lot of correlation, but I was at ease with it. I thought this is still something that's noteworthy, publishable, and telling.
Okay, so this brings me to a hybrid model, a model that uses perhaps both visual acuity and patient-reported outcome measures. And, we're in an era of shared decision-making where it's no longer what the physician says we do. We really work with patients to make decisions. And Some of you may be wondering, where's that physician's perspective? And, I spoke about visual acuity and patient-reported outcome measures, but where does the physician play a role? And as I showed you a few slides ago, there is a reasonably, good correlation between physician opinion and visual acuity. So we thought we could really collapse those perspectives into one metric, which is visual acuity. And also in a tool that we created, which I'll talk about in a few slides, I really speak about where physician input plays a part. And this is another study which is currently under review, which illustrates the importance of using both visual acuity and patient-reported outcome measures. So during COVID-19, waitlists were getting longer, ORs were canceled. So our team identified a need to explore the optimization of waitlists. And just to clarify, this is purely an academic exercise. We never actually changed the waitlist, but we had our first come, first serve waitlist. Then we created a waitlist using visual acuity. So the worst visual acuity was at the top, and we worked our way down. We also made a waitlist based on the CatQuest score. So the worst CatQuest score was at the top, and then we worked our way down. And what we found was that when we used these two new metrics to create waitlists, it significantly changed the waitlist order compared to the original. Both metrics were responsive to cataract surgery. 60% of patients post-operatively showed improvement in both of these metrics together. Both of these new waitlists were significantly associated, while neither were associated with the first come, first serve waitlist. So once again, really showing that there's something going on between these two variables that perhaps we should be considering both metrics. Sweden has tried a hybrid model using both visual acuity and patient-reported outcome measures. So we can see the top two items are related to visual acuity. The remaining three items are related to the patient's voice, glare that they're experiencing, problems with work, driving, and the scores are totaled and they're placed into one of four indication groups. And, this wasn't just an academic exercise. They actually did implement this, and wait time significantly decreased a few years after when they evaluated the tool. And this brings us to, our own tool that we created, a hybrid tool which considers both visual acuity and patient-reported outcome measures. I'll walk you through this tool from left to right. So take in, you have a patient who walks into their optometrist's office. At this point, a rapid appropriateness screen is conducted. So patients who have vision of 20/25 or better, and they report no concerns on their visual questionnaire, we thought that these are patients who are appropriate for deferral, and they end up in our category 4 bucket. So they can continue follow-up with their optometrist. Everyone else is deemed appropriate for surgery and are referred to their cataract surgeon. Once again, at the cataract surgery stage, there is another appropriateness screen, and those patients who have vision 20/25 or better and they report no concerns, once again, are deferred for surgery, end up in category 4. Everyone else is deemed appropriate, and this is now when we can talk about prioritization. So as I mentioned, relatively ranking those appropriate patients on a list. And as is the case currently, medically urgent cases are category 1. We thought patients who were legally blind or unable to drive were category 2A and 2B. And once again, this part of the list, we aren't anticipating to be that long. Most of the patients, the bulk of the non-urgent patients, will be in the vision 20/50 or better category. And this is where using CatQuest can really help us tease out between category 2C and 3. And just some points to mention about our tool here. There are multiple appropriateness checkpoints throughout our tool. I really like to see this as a filter to once again minimize unnecessary surgery, minimize that backlog, and streamline care. And the last thing we'd want is for this tool to be a plug-in model where you sort of put in all the patient's data. We have a wait list, and that's the wait list we're going to use. I really think clinical judgment can and should play a role, especially with disconcordant results, where patients will really benefit from that extra conversation. Take for instance the patient who was 20/25 and they reported everything was wrong. If they had a posterior subcapsular cataract, they may be appropriate for surgery or they may not. And I think this is really an option as providers to speak to our patients about their expectations, temper their expectations, answer their questions, improve their satisfaction, improve our satisfaction as providers, and really improve that relationship with our patients.
So why don't we pause at the tool?
Mm-hmm.
I would be interested in either through the chat or if anyone has any comments on it. Sometimes I feel like tools and guidelines and especially criteria are double-edged swords. There's something being imposed on physicians who have a fair amount of expertise. On the other hand, I feel like if we don't do this ourselves, then someone will do it for us. And we've had this many jurisdictions in the world where different criteria for cataract surgery have been imposed on us. And I think that's why our feeling is we should be proactive so that we do not have to be reactive. The CatQuest questionnaire, Aman alluded to it. There are many countries that have implemented this across, not many, but some Nordic countries that have implemented the CatQuest across their entire cataract base. And my impression, and again, I can't speak for everyone here, is the possibility of have to ask all of those questions to all the patients is just too much for the Canadian context, I think, for the physician and also probably for the patient. And that's why we were quite reassured that we feel like you can ask 3 questions: a very sensitive question, a very specific question, and then one in the middle that has a lot of variability, and you can get pretty much all the data out of a very quick 3-screen question. We haven't decided or determined where exactly those questions should be asked. Should they be done at the referral level? Should the patient log in online to some kind of central system and do them online themselves? Should the cataract surgeon be doing it? Should be done at multiple levels? So there's still a lot of unanswered questions. But I don't know. Does anyone have any thoughts on this tool? Too much? Too little? Not the right approach?
Matt,
The other
did anyone look at monocular patients, whether that be macular issues or other issues as well? Obviously, you have to look at the you need to be a little bit more conservative with these monocular patients, but in terms of appropriateness, is that a factor at all in this?
Yeah, I think great question. So on the appropriateness level, it is done on a monocular level. Okay, the visual acuity, but you can't really tease out patient-reported outcome measures on a monocular level. You can't get the patient, okay, if you were to walk around like this, what would be your ratings on this scale? It just doesn't really work. So monocular patients are basically relying on one eye, whereas the binocular patients, if they have, they're still going to be deemed appropriate for cataract surgery if they have poor visual acuity and no visual symptoms. And that's why we like a hybrid approach. I think you just highlighted another reason why hybrid is important. And when we say hybrid, we are still prioritizing visual acuity. It's a hierarchical model where visual acuity trumps. If someone has 2200 vision and they claim they have no visual symptoms, which has happened many, many times in my clinic, and it's shocking, of course, with that patient, we are still going to advocate for that patient to get their surgery sooner than John Lloyd's patient in Midtown who has 20/30 and is banging down the doors demanding cataract surgery. The 2200 patient is still going first. The John Lloyd patient who's banging down the door with 20/30 vision is going to win out over the other patient who has 20/30 vision, who's kind of like, it's not bothering me that much. So we're kind of, again, we're still trusting the visual acuity, which is what the doctors trust right now, and then giving patients discretion for that large bucket of patients that are kind of in this like regular moderate level of cataract, and really getting the patient voice.
Matt, question for you. First of all, fascinating work. I really quite like this. So a question and a comment. I guess I'll go make the comment first. Is in this province, at least, we have wait time 1 and wait time 2. And for depending on the practice profile of a surgeon, wait time 1 can sometimes be longer than wait time 2. For those who don't know, wait time 1 is the wait to get to the original consult, and wait time 2 is from the consult to the surgery. So a comment might be, if we're going to use a tool such as this, it might be best placed at the time of referral, so that a patient can be appropriately triaged in order to really benefit from such a model. And then my question is, how do we, we have patients who have, for example, mild cataracts in the surgeon's judgment, and other comorbid conditions that are, responsible for the vision loss, whether like AMD, for example. So how would we account for those in this type of model where the vision is quite poor, but the surgeon doesn't feel cataract surgery would be, is not such a priority, but based on vision, they might be falsely prioritized?
Yeah, I think these are good questions. So I'll address the first one, the wait time 1 versus wait time 2. Diana is going to talk to us a little bit about wait time 1, wait time 2, but also about wait time 0. And wait time 0 is, I actually think, the worst of the wait times. It's the patients sitting at home blind who are not even on any wait list. And we still have a lot of those in our society as well. This model is best designed for wait time 2. That's the bottom line. I agree with Amandeep. You wonder, for those patients waiting from the time of referral to seeing the cataract surgeon, this model, it's a limitation. We don't really have a prioritization scheme because we're doing the prioritization based on the cataract surgeon's assessment and not the primary eye care provider's assessment. And I think that is a very good question, whether it should actually be at the primary eye care provider. I think our thinking was that the cataract surgeon who's actually deciding, to do surgery is probably best appropriate to determine that prioritization. But you're absolutely right, Amandeep. We could be asking these questions and doing visual acuity in a standardized way, and perhaps stratifying the wait time one as well. Now, to answer your second question, what about patients who have AMD, so they have 2150 vision? For me, I'm completely comfortable with prioritizing those patients with mild cataracts. They are not seeing as well. Let's optimize just because they're not going to get as much bang for their buck for their cataract surgery, let's optimize their vision. They don't see well. So I'm completely comfortable with letting that go in this system. I know, Katie, I think, mentioned in the chat as well, that there's two ways we could have used prompts. One is just looking at their intake, how poor they're performing, and the other one is look at improvement. And I'm kind of in the camp of looking at how they're doing, or how they're doing now. And if they don't get a lot of improvement because they have AMD, well, we're still just optimizing a blind person's vision, as far as I'm concerned. Should we go on? Mon, you want to do your last couple slides?
Yeah, for sure. So just bringing all of this together, what options do we have? So we have the status quo, which is as we're doing. And as I mentioned, at least from the appropriateness standpoint, 80% of patients that were referred for surgery were deemed appropriate by their cataract surgeon. So it may not be the worst. But on the other end of the spectrum, we have strict criteria like they have in China, where I mentioned, patients who have vision of 20/40 or worse are deemed appropriate for surgery. Or we can have something in the middle where, we're not as unstructured as the status quo, but we're not as structured as criteria. And once we move in sort of this guidelines criteria direction, then we have two options, or multiple options. We can, just focus on visual acuity. As I mentioned, it's great. It's objective standard of care, easy to collect, easy to identify patients who have, poor vision, but we miss out on the patient experience and how their quality of life is impacted. We can see the physician's perspective really overlapping here. And as I mentioned, there was really good correlation between physician opinion and visual acuity. But there's also room for physician's perspective alone, whether it be with just concordant results or medically urgent cases, for example. On the other end, we have patient-reported outcome measures. It's great. We're listening to the patient's voice, but we also have concerns here because, what about those patients who are unable to advocate for themselves? Patients who think if they answered the questionnaire a certain way, they're able to receive surgery at an earlier date, for example. Or we can, create a tool which is done in Sweden, or which we created, which is sort of a hybrid model, which takes into consideration both visual acuity and patient-reported outcome measures. And, this isn't the answer. It's not the only answer, but, there's a lot of different combinations and permutations of ways that we can do this. But, I really hope it creates discussion about how we can optimize wait lists and do best for our patients. That concludes my component. I don't know if we want to do some more discussion or move on to Diana's component, Dr. Schlenker.
Why don't we move on to Diana?
Okay, perfect.
Thank you, Aman. Great job.
Thank you, Aman. That was fascinating.
So, hello everyone. We are gonna change here a little bit the topic, but we'll continue talking about the tool later. So let's talk about risk communication in cataract surgery. This is our team for this project. So I will start with a poll. And so how do you usually break down cataract surgery risks to patients? Do you use a positive approach and negative approach? Do you use both interchangeably? You don't really know and haven't really thought about it, or you don't think it really matters?
We'll let that run for a second. So Diana, you have a clear-cut winner here. People use both interchangeably.
Okay, that's really interesting. So we'll discuss that after. So risk communication is essential in shared decision-making and evidence-based patient choice. We essentially have two ways of presenting the risks. We can do it in a positive way or gain way, in which we say percentage of efficacy or the benefits of getting an intervention. In a negative way or loss way, we will say what are the consequences of not getting this treatment, or what are the inefficacy of certain intervention. We wanted to check how was the framing impact in cataract surgery patients and their perception of risk. So what did we do to evaluate this? So we recruited and randomized 100 patients with 50 in each group. Based on the group, these were patients that were being referred to cataract surgery, but that had not yet made the decision to undergo surgery and have not yet seen the ophthalmologist. And then we educated them on the risk of cataract surgery based on the group they were allocated to. So in the positive group, we presented the risk as more than 99% chance of healing without severe complications. And in the negative group, we said less than 1% of experiencing severe complications. And then we move into the assessment of risk. We put a scale and they had to rate from 1 to 6, being 1 not risky at all, and 6 really risky. So these were the baseline characteristics of our group. As I say, we included 50 patients in each group after 50 interviews, and there were no significant difference between both groups. We have a really diverse group in general. The majority were Arab and West Asian. Mean age was 70 years, and the majority of our patients were female. The average waiting time for the cataract consultation was pretty similar in both groups. And here's some other baseline characteristic. Majority of our patients were 20/50 or better, and they were really dissatisfied with their vision. So moving into our main outcome, we found that there is a higher risk perception score in patients where we presented the information in a negative way when compared to the positive way. We find significance being the median for the positive group 2 and for the negative group 3. So here we can see in the graph, there was a difference between how we presented the risks.
Let's just pause there for a sec. So our poll question made it very clear that people are using these interchangeably, but you know, and again, I don't think this was a huge surprise to me. I think that this is why lottos work. You know, there's a lot of things in society where clearly we underweight or overweight depending on how things are framed, and these have been exploited. You know, this is what behavioral economics, you know, and some in game theory, what we see. And you know, I actually find it a fairly striking effect size that even though the quantified numbers are the same, depending on how it was presented to the patient has a substantial influence. And I guess that's, you know, for later or put in the chat, you know, trying to figure out which one is better. How should we be doing this, or is it manipulative to be potentially using a positive approach for patients who are really pushing to have surgery, and a negative approach for those that you're not sure need surgery? Is that manipulative, or is that just being a good clinician?
Okay, so we decided to also do some exploratory analysis to see if there were other factors or demographic characteristics that were associated with the risk perception. So for age, we found no significant correlation. We checked by gender also if there was a difference in the scores that patients were perceiving, and there was no difference here as well, and also no relation to visual satisfaction. So we did find that there was a higher risk perception in the negative group compared to the positive group. There was no statistically significant demographic characteristic that was associated with risk perception. Even though it was small, just including English-speaking patients, it is important to acknowledge that the key takeaways are that communication delivery matters, and that the way we present our information does have an impact in patients' perception. And when we are considering effective health communication strategies, we should take into consideration the impact that how we frame our discussions with patients does influence their perception and how they are seeing this information. So next steps will include a larger, more diverse patient population, and we'd like to investigate as well the effects of this framing on actual behavioral change, on if this influences uptake in cataract surgery. I don't know if we should move to the next one, Dr. Schlenker.
Yeah, I think so. I mean, anyone can put it in the chat. It said, is there a right way to do this, a wrong way? Should this be standard? Should we be teaching our residents that positive framing is the right approach? Negative? I don't know the answer. I think we were just really interested to know if it really in a fairly simple study, whether trial, I should say, whether we could see an effect, and it seemed like we saw a fairly notable effect.
Now we're moving into our current focus, one of our current projects. And this is on setting the foundation for the development of a new cataract care model that considers patient and provider's perspective. So a continuation of what Aman started earlier. So first of all, let's start with a poll as well. And what do you think is the main reason why we have people coming in blind in Canada to their consultation? So we see geographic disparities, some cultural or language barrier. Is it the limited availability of services, cost-related barriers, even within Canada, or is it a lack of awareness in education in eye health?
Thank you, Diana. We'll let that run a little bit, but I think it seems, the early poll results are a bit of a mix, which makes sense given our system here. There's a bit of all.
Okay, so that's interesting. Yeah. So the lack of awareness is the winner here. So that's pretty interesting. Let's continue with the discussion of that. So we were wondering the same. We were wondering, why are patients coming in blind? We find this in risk communication study first, that patients were coming legally blind, count fingers, to the first appointment with the ophthalmologist. But before we move on, I know Dr. Wright already mentioned a little bit on wait times, but this is it. So wait time 1 is time from the referral to the consultation with the specialist, and then wait time 2 is time from the consultation to when they get surgery. But what about wait time 0? What about the time where patient is at home, needing to be seen by somebody to be assessed, and not getting into the primary care to get a referral to where the patient needs? So what do we do to explore this? We decided to conduct semi-structured interviews. So we have 2 groups: patients, which were referred for cataract surgery and had a 20/200 vision or worse. And then we were sitting down with them and asking them about the barriers and their journey to accessing care. How was the whole process, how long it took, and what were the main factors that hindered this process? And then we sat down with primary care providers and asked them about which criteria do they use for referrals, and from the provider side, what are the hindering factors in the cataract referral process. So this project follows a 3-phase approach, and for today's talk, we are going to focus on the results from phase 1 and phase 2. So these are the baseline characteristics from our first phase. So we included a total of 20 patient interviews. The mean age was 70 years old, majority were female. Median wait time 1 was 47 days, and median wait time 2 was 63 days. The majority of our patients had post-secondary education and were white. So how did the journey start? So for the majority of patients, the optometrist was the first person that they saw with an eye, some complaint about their vision, followed by the family physician. The main person making the diagnosis was the ophthalmologist, and in average, patients were experiencing 3 years of visual impairment before being seen for the first time. So this is a chart that shows how's the journey for patients. When we were asking about the barriers for accessing care, the majority of patients answered, and I have some phrases, some quotes from the patient interviews here. When they thought it was normal to lose vision, they didn't know there was something wrong they could do to fix. And we followed by the fear of surgery. So many patients are still reported being afraid by something going in their eyes, or eye surgery sounds pretty scary. And we still have an impact here from COVID-19, where patients were being afraid of going to the centers and getting exposed to the virus. And of course, some difficulties with the healthcare administration when they couldn't get a hold of the appointment, they couldn't get an appointment. And yes, those were the main barriers that we identified here. And the main motivations to seeking eye care was the impact on daily life. The activities that were mostly impacted were driving and reading, but we also saw some patients reporting falling even inside their house, needing assistance to be like just walking at home, and patients saying that they couldn't read any labels or anything when they went grocery shopping. We even have 2 patients that they first had a car accident before they realized they had something wrong and they had cataracts, and there was something to be done about that.
Yeah, and I just pause there for a sec. You know, the driving I think is particularly scary. This is self-reported driving difficulty. I think we've all encountered patients who clearly should not be able to drive well, though will reassure you up and down that they have no problem whatsoever driving. I had a lady recently, and she's like, well, my mom is a very anxious person, and the fact that she's not anxious while her husband is driving is the indicator that everything is fine. And I said, I can't tell the ministry that I was reassured by the wife not freaking out while he was driving as a reason to not report to you to the ministry. You know, so like 65% of them self-report, I think is fairly concerning. All the more reason, of course, our goal is to help these patients, but it's also to help society.
Okay, so moving into our second phase, we interviewed 10 optometrists, 6 family physicians, and 4 ophthalmologists, and we asked them about the whole process as well. So for the majority of optometrists and ophthalmologists, they use a combination of both objective, subjective criteria, and majority also consider demographics as patient age, occupation. But on the other side, we have family physicians where the majority just uses subjective and demographics. Many of them told us we don't have a Schilling chart. We don't usually check anything objectively. We rely on patients' visual demand and their complaints, and then bringing that up. So this is among optometrists and ophthalmologists. This is what they usually use. First of all, the main one was visual acuity. We have seen that before. But within this one, we find differences. Some doctors saying 2030 is when they start a conversation, but for some others, 2040 is when they will start considering it. But they also consider slit line findings, some ocular complications, on if there is like obstructing the vision, like of the posterior pole. And the subjective criteria mostly considered was patient visual demand. So many doctors said that even though the VA may be fine, if their lifestyle is affected, they will decide to refer. Family physicians told us that if patients report that they were falling at home, they were having falls, that's a sign to report to the ophthalmologist as well. And about the factors that influence referrals to ophthalmologists, the majority of providers told us that wait times is what they guide their referrals based on. So referring to the surgeon that has the shortest wait list, but also location and reputation and bedside manner also matter when doing these referrals. And the main factors that they experience as a provider doing referrals for cataract surgery were the lack of referral follow-up. So that's what brought up a lot. So we interviewed 16 of the total providers that refer, and 13 brought up that not getting back a note from the ophthalmologist office saying that they're going to accept the patient, or they're not going to do that, or that patient is going to have surgery, or keeping them more on the loop facilitates or hinders the continuity of care of them for the patient. And followed by the lengthy referral time and administrative issues when they cannot contact the ophthalmologist office. So we first of all have to acknowledge the limitations of our study. So it was a small sample size. We narrowed geographic scope, and we had selection bias. So we are still missing the perspective from patients that did not seek care. We are seeing the patients that somehow after a while made it to come and see us. But what about the ones that are still sitting at home or still driving that have not yet come to seek eye care? So our findings overall are that optometrists are the first contact, which opens again, followed by family physicians, which opens the fact that continuous communication with our colleagues is key. Lack of awareness and fear of surgery are the main barriers to accessing care. And there's definitely different criteria used between providers when deciding patients for cataract referrals. Optometrists rely more on objective as subjective criteria, and family doctors more in subjective criteria. So we open here bunch of interventions that could be done. So raising people awareness and increased patient education is definitely something that was brought up here. And early detection strategies at primary care, such as screening tool, definitely help. And regarding the provider side, there are efficiencies to be gained by having a cataract and appropriateness and prioritization tool, kind of as a guideline for this whole process. What's next for us? So we are now focusing on phase 3, in which we are going to use the tool that was presented by Aman, and then we are going to show it first to 20 patients to see if they understand. It's a pilot testing, understand the layout, they get the questions, checking different literacy of patients to see if they understand what we are being asked, and then pilot testing it in real world of a clinic functioning to see which is the best way and in which time to introduce this tool. Yeah, so that's.
Thank you, Diana. That was great. There's a comment from the chat here as well that I'll just share with you guys. Paul Sia says that in New Zealand, they use a similar system, but they combine, patient symptoms, vision, they grade the cataracts, and then come up with an ultimate score. And so, it's similar to what you guys are describing here, but I think, as Matt said earlier, other jurisdictions are already using such systems, and it's likely clear that we're heading down that direction as well. We just have to figure out how it works, I think, best within our system. So thank you for sharing that, Diana. Any thoughts from you?
Yeah, I mean, just to build on, Paul's comment, if the government in Canada does come to us and say, I could go either way. They could say hard visual acuity cutoffs. I think now we have good literature in a Canadian context that hard visual acuity cutoffs have severe limitations that is going to inhibit care. Mm-hmm. And they could come the other way and say, no, you just have to ask the patient. And there again, I feel like we are going to have a fairly good rationale to say it's way oversimplified. And again, you're going to lose basically the compromised in our society by just asking the patient. So I'd like to think we're ready. The harder part is actually proposing something that you can implement. I don't know. I'd be interested to hear from Paul of how much work it is to implement that scoring system that they're doing in New Zealand. Some societies, I think, have a different appetite for a lot of intake work. And again, I think I'm sensitive to it as a clinician. I do not want a lot more intake work. Even our current wait time initiative, I think, is incredibly flawed. I don't know why it's been pushed onto the physician offices, an administrative burden put onto the physicians, especially in an era of big data and in a universal healthcare system. I think this can be done quite easily centrally. That's another area of our research that we're working on. On the other hand, the patient-reported outcome measures, I do think we're going to have to start to step up and do a little bit more. That doesn't mean that the clinician, themselves have to do it. It could probably be a technician who does it, just like our technicians check the vision right now. There's no reason why we couldn't ask a few screening questions. Again, in Singapore, you can ask someone like 30 questions and they just answer them all. But in Canada, I don't know if that works. So that's why, again, we got to be a little bit proactive and figure out something that will work for our system.
Yeah, I think the point you made about both the visual acuity and the CAT Quest demonstrating their utility is a really good one, because I think as clinicians, I think naturally people are going to be a little worried about being dictated to about their practice by a non-clinician. But I think the point you're making here is very good and very reassuring to clinicians.
And something else we didn't talk about. I mean, Alan has a lot of experience, but I think we all do, that patients will perform poorly on the CAT Quest when they have dry eye. Mm-hmm. And we've all seen a patient have dry eye treated with cataract surgery, and it's not a good treatment. In fact, at the beginning, in fact, at the beginning, they're worse. And that it doesn't really come through in our research, but hopefully if the government were to just say, any patient who has glare, just give them cataract surgery. We need to be able to push back with gusto and say, no, no, it is much more complicated than that. Because again, this is very multifactorial. Now, of course, visual acuity, the tool does not completely address the dry eye issue, because visual acuity can also be disrupted quite severely with dry eye. So a patient could, again, in the wrong setting and without proper clinical judgment, score poorly on calculus, score poorly on visual acuity, and again, get cataract surgery for their dry eye. So that's why we got to be a little bit. That's why Amin talked about the guidelines versus criteria. I think clinicians like guidelines and government like criteria, and I think we have good reasons to advocate for guidelines.
Matt, it's not just dry eye, it's any kind of ocular surface disease, pterygium, Salzmann's nodules, basement membrane dystrophy. And that's where, your point was really dead on about a multifactorial approach to this. But I love your idea of, being proactive and before things are put on us. What are your marching orders, given all this research that you've done and presented so nicely? What do we take moving forward?
Yeah, I mean, I think so. We did a symposium there in the spring, which actually, Aman and Diana basically ran the whole symposium, and we were able to bring some international people as well to look at this. And I have to say, one area that I was particularly impressed with in Canada, just down the street, is the Kitchener-Waterloo area. Where the Kitchener-Waterloo area, Toby and one of our alums, Carissa McAllister, have really taken upon themselves to come up with a system, a little mini system there with transparency, education, centralized, and it'd be very easy to plug in a little bit of a patient reported outcome measure into there. And I just feel like, and they've actually been well supported by they've integrated well with their local government as well. I think it's a mini success story of showing that, again, they were proactive. They didn't have this imposed on them, and they're doing it in a way that works for their area. And I said, I think we can all think of other interventions that have been imposed on us. I just gave one example. I think the wait time initiative that's been imposed as an administrative burden on clinicians, that is just frustrating. Where if everyone did what Carissa did in Kitchener-Waterloo, the government's not going to impose something like that, because I think the government's probably very impressed with what they're doing, and I was very impressed with what they're doing. So just a little bit of an example where it's very easy for us to get caught up in our busy clinics and not worry about some of the health system issues. But it's probably more important to do this than figuring out a little bit better way to do the cataract surgery itself.
There's a
Might be
comment
interesting
from
to have-
Wendy Hatch, just suggesting that rheumatology has been having patients fill out the prom survey while in the waiting room, and that may be something for us to consider as well. Of course, there could be language barriers and whatnot, but perhaps the majority of patients could get it done while waiting to see us.
Yeah, definitely an area of our research, and we don't know the best way to do the intake. And, we showed in our middle research bucket that how you ask questions, the context which you ask questions affects too. So we want to be thoughtful about how to do this. And again, because I'm a clinician, I want it done efficiently as well. I wouldn't want it done in a way that's really bothering both the patient and the clinician offices.
Okay, well, thank you, Diana and Amin, for your wonderful talks. Thank you, Matt, for the research and leadership that you're showing Ontario and Canadian ophthalmology in this regard. Fascinating work. I look forward to the next update to see where you guys end up. Thank you for all the work that you're doing. Thank you for the presentations this morning, and I hope everyone has a good Friday.
Thanks, Amandeep. Thank you, everyone.
Bye.
Great job.